Hello everyone, welcome to the 8th webinar in the Hermes Educational Series. My name is Steve Bloomer, I'm the UK Business Manager for Hermes, and I've got great pleasure of introducing today's speaker, Dr. Charlotte Fowler, who's a consultant radionuclide radiologist at Guy's and St Thomas's and a long-standing customer of ours. Charlotte's got a wealth of experience across the full breadth of nuclear medicine and a special interest in cardiothoracic imaging. And she's also the nuclear cardiology lead for Guy's and St Thomas's in London in the UK. Charlotte is also the UK training program director for nuclear medicine physicians. Today, Charlotte will be presenting on the technical and clinical advantages of VQ SPECT imaging, including development of quantitative applications. And she's also kindly agreed to take some questions at the end of the talk. So if you think of a question during the presentation or during the Q&A session, please do post it in the chat facility and we'll be sure to raise this for you at the time. Just to let you know, this webinar will be recorded and will be posted on the Hermes website for availability later. And with that, I would like to introduce you to Charlotte in person and hand over to you, Charlotte.
Thanks, Steve. Thanks, everybody. Thanks, Hermes, for giving me the opportunity to do this. I just need to take away the picture of myself that's in front of me before we can crack on. So thanks for joining. I've got 133 I can see in the audience so far, so that's just excellent. So I'd like to talk about the technical and clinical advantages of VQ SPECT imaging, including the development of quantitative applications. I'm talking today for Hermes, but I work for Guy's and St Thomas's and also for King's College London. So that's me. Just to give you a bit of the background, I did a biology degree originally at Oxford. Then after working for a while in industry, I went and did medicine in Cardiff, where I started my interest in nuclear medicine. With John Rees in Cardiff, and then transferred to London, trained at Great Ormond Street in Cambridge, where I did radionuclide radiology, and I did the King's College MSc. And I then did an MD in dual isotope breast sentinel node. I'm only telling you that because it has relevance to what's happening later. The giants amongst my nuclear medicine teachers are John Rees, Isley Gordon, and of course Mike Peters, who are wonderful and inspired me endlessly. So I've actually had 4 consultant jobs, which is rather a lot. I like to think that I've always left under good terms, but each job was different in terms of its opportunities. So I worked at Luton, Harefield, Brighton, and Guy's and St Thomas's. And if anyone's there from any of those here from any of those centres, I'd like to say hi. And my screen hasn't moved forward, which is a bit strange because it did before the. Anyway, I'm just going to see if I can get my mouse working. And also, just at the moment, I'm the clinical module lead for King's College London Nuclear Medicine Postgraduate Programme. As Steve said, I'm the UK Training Programme Director for Nuclear Medicine Physicians. That makes me the chair of the Nuclear Medicine Specialist Training Committee and also a member of the JRCP-TB Specialist Advisory Committee for Nuclear Medicine. And I have been on RSAC and BNMS Council. So carrying on, I'm grateful for many things during this time of difficulty, including particularly technology. We've all benefited very much from all the different aspects of linking up digitally, and thanks for setting this up. First of all, I'd like to talk about the Emm Guidelines and how we can introduce that with SPECT with dual isotope tracer use, how we can benefit from adding SPECT to CT for helping establish correct diagnosis. I'd like to talk about lobar quantification and PE quantification, which is work in progress with us. So where were we? Nuclear medicine has always had really strong association with lung imaging. The planar images that we have produced over, decades of use were absolutely marvelous, particularly when they were very normal, such as in this case. A normal perfusion scan essentially excludes PE, or when, like in this case, we have multiple defects on perfusion, which is mismatched on ventilation, typical wedge-shaped mismatches, which give us typical features of multiple large PE. So at both ends of the spectrum, it's terrifically easy to work out what's going on. Unfortunately, in the middle, I'm having trouble with my mouse, I do apologize. In the middle, it's not so easy. We've got problems where basically we don't have high or low probability. All the intermediate scans across the center of it really do create a bit of a problem for us. And that's because of taking into consideration the patient's pre-test probability, which is part of the pipette criteria. We have pre-test probability on the left here, an interpretation of VQ across the top. If we have sort of scans which are normal, it's no problem at all. Our positive predictive value is very low no matter what the patient's pre-test probability is. And it's very high if we've got that picture with multiple wedge-shaped defects that we were talking about, especially if the patient's pre-test probability is high. But for almost all the other situations, all the patients in between that, in fact, we end up with rather difficult to interpret positive predictive values, sort of between 20 and 70%, which is not very helpful. And those patients need to have further clarification with CTPA, which was actually required in about 20% of planar imaging. So what do our referrers want? They really want not 50 shades of grey, where we say that there may or may not be a PE. They want to have black and white. They want us to say whether there is or there is not. So we need to work to provide that kind of level of clarity for our referrers. They really don't like the probabilistic scanning type of report that we used to produce for planar images. Of course, CTPA is wonderful for this. We have a filling defect shown in the right pulmonary artery here, and that is very black and white. It's easy to be very confident what's going on in that scan. And CTPA, with the introduction of helical images, basically because of the increased sensitivity and specificity of CTPA compared to planar VQ and improved accuracy as a result of that, in many centers, after the introduction of helical CTPA technology, we found that VQ is being used less and less frequently. The Emm Guidelines in 2009 changed all of that. We saw a switch from the recommendation for planar to spec VQ. And in that, we had very clear guidelines where PEs were being described if there was a VQ mismatch of at least one segment or two subsegments that conform to the pulmonary vascular anatomy, and no PE for other situations. So for those of you who don't know, what is spec VQ? So this is planar images. I'm going to just use this as an example. So planar images where you have the gamma camera head above, anterior and posterior to the patient, and left and posterior obliques. And we end up with planar views, anterior, posterior, left posterior oblique and right posterior oblique. And we have the perfusion and the ventilation images above and below each other. This is a normal scan. For SPECT, we have the gamma camera heads on either side of the patient in the same way, but this time the camera heads spin around and we then end out with a 3D image set generated from the planar data views. So here's the tomogram. I hope you can see this okay. There was a bit of a lag when I tried this kind of stuff a bit earlier. I'm going to scroll through slowly. And then when those volumes are processed into the 3 coronal planes, we can then end out seeing images such as this, where we have the perfusion on the left, the ventilation on the right, and those are SPECT VQ images. And we can see them in the different planes. So on the left here, we have coronal images, sagittal images, and transaxial images. And as a result of looking at the different orientations of the scan, we can make a good diagnosis. And here's a patient with the ventilation above and the perfusion below showing those multiple wedge-shaped defects. So this is a patient with PE. The sensitivity and specificity went shooting up really from between Planar and SPECT VQ. You can see that the sensitivity increased from only 75% to the high 90s. The specificity also increased from 85% to 91%, and as a result of that, the accuracy was very good. You can see, in fact, the sensitivity is a bit higher than on CTPA, and that's because VQ SPECT is much better than CTPA at identifying clots that are in the small subsegmental arteries. Those arteries are too small for CT to define them. So with these compelling results, why is it that all departments aren't offering SPECT VQ? And there are many departments that are still not. What are the blocks? So assuming SPECT capable gamma cameras, which all departments will now have, what are the disadvantages of SPECT VQ? Well, you can't do a quick erect scan. So in certain patients, you won't be able to do scanning where the patient can't tolerate lying down. So if the patient can't manage supine, then you can't do a VQ SPECT. You do need advanced image display because you need to be able to scroll through the different data sets. Ideally, you know, perfusion on one side, ventilation on the other, scroll through them to allow them to be viewed alongside each other. Those have to be perfectly matched. You can't have any mismatch in that. You need to have systems in place that will allow that. But most PACE departments now have a good PACS working system. Then moving on to the third problem, it's the doubled imaging time. So it probably takes between 15 and 20 minutes to do a high quality planar VQ scan. And of course, if you have to do double SPECT images, that doubles to probably 40 minutes. So that's where I come in with my interest in dual isotope work. We were looking at dual isotope using Krypton. So we were familiar with Krypton from doing planar images, and planar VQ with dual isotope Krypton has been done, you know, for a long time. Krypton's a true gas. You end up with getting excellent quality images, very low, practically negligible dose to the patient, very low staff dose because there's no problem with room contamination. The problems with it, though, is it comes from a rubidium generator. That has a short half-life. You need to have a new generator each day. As a result of that, it's very expensive and it's not widely available. But if you can get hold of Krypton, it's a terrific tracer to be used. Here are just some planar images with it. What's great about Krypton is because of the difference in the emission spectrum, we've got technetium and Krypton here shown side by side during simultaneous acquisition. If we then look at the technetium alone, you can see that there's really very little downscatter. There's not much difference between the bottom of these two graphs. So we can confidently acquire images using MAA labeled with technetium and Krypton ventilation images, and we can acquire those simultaneously. And we're used to doing that for planar images. And here's a data set, and I'm just going to point out one of the interesting sort of physics points of it, which is because Krypton has a slightly higher photon energy, it has more penetrating power. So the cardiac outline that you see defined on the technetium MAA image is lost. So that is a sort of technical mismatch, if you like. So it has ideal physical and physiological characteristics, being a pure gas, a negligible dose, perfect image co-registration if we do it with simultaneous dual isotope with perfusion imaging. That allows you to halve the overall scan time for patients. That not only makes your throughput of patients through the department much more efficient, but it also, of course, makes the patient more comfortable. You're less likely to have problems with movement. You get higher quality images and higher patient throughput. But in 2009, when this was introduced, I mean, ages ago now, isn't it? Over a decade, but there were many technical questions about how to convert the dual isotope technique from planar to SPECT VQ. We had questions about collimators, matrix size, the SPECT acquisition protocol, the angle, the orbit, the time for each acquisition, what reconstruction should be used. And there was some concern about some physicists about whether dual isotope VQ SPECT would actually reduce the quality without the use of specialized krypton collimators. We were concerned about the possibility of downscatter from the krypton window into the perfusion window and reducing the sensitivity of the test. We really didn't feel able to start with dual acquisition without doing some further work. The radiographers and nuclear medicine technologists that I worked with at the time also were very keen not to have to switch collimators between the perfusion and the krypton acquisition. So we wanted to find collimators that would basically allow us to do both acquisitions at the same time, but that would end up with really good perfusion images and good ventilation images as well. So before introducing a clinical service, we decided we needed a phantom, which would allow V and Q concurrent imaging. We wanted to look at some matched and mismatched defects. We wanted to see whether it's quantifiable, reproducible. And because lungs are like sponge, we decided to try using sponge as our phantom basis. And this is all thanks to Chris Baker, who is a physicist working with me at Harefield at the time. And he kindly went out and actually bought a whole pile of different sponges that you can see here, just to try it out, to see whether we could have a sort of proof of concept, if you like, to see whether the sponges would actually absorb isotope nicely, and they did, as you can see here, to a different degree. And then we wanted to see whether we could actually ventilate them at the same time. And we struggled to find a sponge that would work, but we did in the end, after liaising with a specialist sponge manufacturer. And so this is our sponge phantom, and you can see that it has some defects in it. The defects with the top, you might recognize this is a vacutainer and this is a medical sample bottle, are matched defects, and the ones that are open are our ventilatory mismatch defects. So this is the perfusion images from this phantom, and this is the ventilation images. You can see that the ventilation images show the krypton actually filling up the whole of the lunchbox. But we can see from this image here that we can identify the match defect with the perfusion image and the mismatch defect. And we've also got these very small ones, which you can just identify here, and we can see it on this one as well. So this was our early phantom work, and we could do some quantification by looking at count profiles across them. And of course it was called SpongeBob because it was a sponge and it's square, and we could just about make it out of the name. So this is our SpongeBob phantom. And some work was done with Leeds test objects, and we have a prototype for this, which is still doing the rounds of various hospitals, but basically it's got some perspex around it to add some scatter, but it's essentially the same. So here are the results from Guy's and St Thomas's, for example, with thanks to Chris Sibley Allen for these. Basically lots of different collimators, different matrix sizes, different views, and here we have the ventilation images and the perfusion image, and this is a gold standard perfusion standalone. And so we wanted to see whether this particular range was best, and it looks like this is the best arrangement number one, so that's the one that we use. So we use this protocol. So good to see that this approach was endorsed by the ENM when they published their new guidelines in August 2019. You can see that at that time the ENM committee agreed that it could be acquired simultaneously. That was a bit of a change actually since 2009. I remember speaking to Dr. Bach when she presented this at Oxford and asked about krypton, and she didn't think it would work, but it's good to see that this this has been endorsed. So using dual isotope spec VQ, acquisition times are then similar to planar images, allowing an efficient service equivalent to planar imaging with results which are equivalent to CTPA accuracy. So that's really great. But with spec data, you have some additional opportunities. What else can we do? We've still got this specificity of only 91%, and it would be very nice to be able to improve that. And we can do that by co-registering with CT. Here are some nice examples. So here is a patient with what looks like normal ventilation on this coronal image, but on the perfusion scan, we can only see left lung. The right lung looks like it is entirely absent. And if you were just reporting this from a VQ perspective, you'd be suspicious that this might be a massive PE obliterating the right pulmonary artery. But actually, when we look at CT, we can see that it's because there's actually a congenital right pulmonary atresia in this patient. So she has a completely normal lung, but it just has no pulmonary artery supply. So as a radiologist, of course, we do this instinctively. We move between different protocols, different modalities to try to work out what the problem is due to. But if we look at other areas which are more typical of VQ, PE positivity, such as this one with large apical defects, which have like a rather wedge-shaped morphology, and you'd be very suspicious about this if you just had the perfusion and ventilation images. In fact, when we look at the CT, we can see that there's absolute destruction of the internal architecture of the lungs on this scan, and that's the reason why this area appears ventilated is because the ventilation agent, the krypton, is just seeping across into the apices. So a very important false positive has been avoided by checking the CT scan. And you don't even have to have dramatic abnormalities on the CT to avoid mistakes. There seems to be a strange normal variant where there's poor perfusion going right up to the oblique fissure on the right. And this defect here will actually splay across both sides of the oblique fissure. And so that is actually a sort of normal variant due to the oblique fissure. So adding a low-dose non-enhanced CT to spec VQ can reduce our false positives. And that has been endorsed by the Emm Guidelines from 2019 as well, where VP spec CT has similar sensitivity as VQ SPECT, but slightly higher specificity. We audited our results at Guy's and St Thomas's. This was an MSc student project, just to see how helpful is the CT component, and can CT be used as a ventilation substitute? How often could we look at a CT scan and say that CT is entirely normal, let's not plan to do a krypton ventilation? So we had 13% of our patients were positive for PE using VQ SPECT CT. Without CT, we would have had 18% positivity. So we had 5% false positives if we just used VQ SPECT. And if we ignored the krypton side of things, we would have had 21% falsely positive. So we would have had, 21% positive. So the difference between that and the true result was 8% false positive. So we found that CT contributed positively not only to the diagnosis of PE, but also to wider abnormality identifying other aspects of interest. So we found that with the radiation exposure of around 2 millisieverts, addition of CT is definitely justified. Of course, it's very easy with a SPEC CT camera, but I would also just advise people, if they don't have SPEC CT, to compare to a separately acquired CT. So our routine protocol at Guy's and St Thomas's is, unless patients are pregnant, all patients get a low resolution CT at the end of VQ SPECT for correlation as part of the routine scan. That scan is actually acquired in just quiet breathing so that we can co-register it with confidence. That's the radiation exposure. And we also help to get anatomical information for causes and, of course, pathological ones, such as 1 or 2 patients who've had quite striking abnormalities that we've picked up on the unenhanced study, such as a cardiac tamponade in one patient. So as a result of running a service such as that, demand for VQ has increased by 16% over the past 5 years at Great Ormond, at Guy's and St Thomas's, and that's been pleasing to see. What other services should we be involved in, given our ability to identify subsegmental PE? And my first bit of advice really is to get involved in the pulmonary hypertensive service, because small subsegmental PE is one of the curable causes. Here's a patient that was actually imaged, I think, only yesterday in our centre. So this is a 23-year-old male who's been chronically short of breath following DVT and PE, and he now has pulmonary hypertension. His CTPA was negative, but he has these very small peripheral perfusion defects, which of course is very important diagnosis to make so that he can have his curative surgery with end arterectomy. COVID, of course, has big implications for us because it causes a wide range of thrombotic problems, which is common with COVID. We find that we have a high incidence of DVT and PE. And not only that, but we have the new phenomenon of inflammation-related in situ pulmonary thrombosis forming, which of course our study can demonstrate very nicely. Chronic PE or pulmonary thrombosis is likely to be responsible for some of the long COVID cases. We've actually continued to run our service throughout the COVID pandemic. Guy's and St Thomas's, I think, was one of the first centres to actually have patients with COVID in the UK, and probably will be one of the last. But we have continued to run our service throughout. We have used Krypton, not DTPA, and of course we make sure that staff have appropriate PPE. I'd just like to show a couple of CTPAs just to show the kind of range of abnormalities that we can see. So sometimes this was a positive patient for PE, and you can see that all we can see is like a very wispy little thin strand of PE in an otherwise normal pulmonary artery. So that's the sort of normal PE. But then we also get this kind of picture where you've got a pulmonary artery. This is pulmonary veins here, so we'll ignore that. That's the left atrium. So here's the pulmonary trunk coming across here, and we can see that there's just obliteration of this, but it's kind of coming in from the side with lots of little strands running along the pulmonary artery, coming in from the edges. So it's a very different picture from the one that we are used to seeing with a filling defect with a ring of contrast around it. We see much more kind of chaotic process with these in situ inflammatory thrombi. So here's a case, 57-year-old lady. This was her chest x-ray back in April. She was previously fit and well and had COVID. And she's now having imaging back in November when she was still symptomatic, and her CTPA and her dual energy iodine map that's carried out as part of her CTPA process is also unremarkable. No defect was identified on the iodine map. But on her VQ SPECT, which we can look at here, so here we've got ventilation and perfusion for transaxial, coronal and sagittal through the left lung. We can see that there's a defect on the perfusion image here, which is not matched on the ventilation image. And when we compare it to the CT, we can't see any anatomical abnormality that might explain that. So this has all the hallmarks of a PE, and here it is seen on the quotient image as well. So we were able to diagnose this PE that was negative on CTPA. So it's been a very nice article written by our colleagues from Imperial that was published recently, and I'd like to commend it to you. Beyond the clot perfusion imaging in of pulmonary vasculature after COVID-19. We think that there's a very important role to be played, and we're seeing patients routinely coming for a post-COVID follow-up in patients with long COVID type symptoms. So having optimized VQ services for PE and now sadly pulmonary thrombosis diagnosis by introduction of VQ SPECT CT, what else can we do to improve? So I would like to make our images more accessible to clinicians and patients, and one of the things that I quite like doing is surface rendering, so I'd like to show you some of that. This is the same patient that we were looking at. So on the left are perfusion images, and on the right is the ventilation images. And I just think that this is quite a nice way of looking at these scans. And we're coming in now to that defect that we saw at the base on the left, and you can see that there's quite a nice defect demonstrated on the surface rendered perfusion image, which is not seen on the ventilation phase. And I think that, you know, if you showed that to a patient, they would understand it. And I hope that we're all on the same page now, because I think there's been some lag, but I'll just take my time over this one to describe it to you. This is the small pulmonary emboli that we saw for that patient, the young man, the 23-year-old with small subsegmental PE. But this is just to show you what his surface rendered perfusion images look like. So on the ventilation images, it's nice and smooth there, but it's punched out on the perfusion images. These are surface rendered images were created through using Singavir, which is a Siemens advanced software. So apart from that, what else can we do? We can improve the quantification service for our thoracic surgeons. So planar regional quantification was used in the past, and we used to create these rather strange transaxial zones. So we would have an apical, a mid, and a basal kind of block, like a Lego block, going through the lungs, which of course there were absolutely no reference to the obliquity of the images that we see. So this is looking at the left lung. The oblique fissure will come right the way down here, and the upper lobe actually extends right down into the base on that side. So I think that we can do a lot better than just producing the 3 blocks that we have done previously using planar images, which of course we had no choice about because we didn't have the technology. But now we can segment the lungs accurately using the fissures from the CT to define the lobes volumetrically and allow volumetric quantification, assess the counts within each of the lobes, and then actually work out which lobe creates how much, supplies each in terms of the total global perfusion and ventilation. And that really does help assist in thoracic surgical decisions. So this was a technique that we developed first of all at Harefield, and we used the Siemens system, as you can see. We actually gradually, oh, I don't think it's going to work. Sorry, just flicking backwards and forwards now. What I wanted to show you, and if I'd been able to, I've got problems with my mouse for some reason, which is why I'm a bit anxious here. So I would have shown you that it's possible to build up the volumes of each lobe by basically doing a region of interest around a planar image, and then you can squash them all together to create your volume. And we did that using a Siemens technique. And we were also able to, at the same time, at a different center within Harefield and the Brompton, actually at the Brompton, they were doing the same thing but using the Hermes system. So this is the Hermes method. You can see top left, top right hand side, you can see the dots along the fissures. So basically put dots along each of the fissures to actually form the volume of the lobes. Our results when we compared Harefield with the Brompton, so this is the Siemens sort of patch it together with the Hermes results, was really very good, and we were pleased with that correlation. So excellent agreement between the two techniques. We found that SPECT VQ CT lobar quantification is reproducible across different manufacturers and therefore appears robust. The two techniques can be used interchangeably in clinical practice, and the new technique was received really positively by thoracic surgeons planning lobectomies or bronchoscopic intervention. So this is just an example of the sort of results that you can get these nice surface rendered colored lobes and the results, as you can see here. Here's a clinical example. So this is a patient who had apical bullous emphysema, and he was being planned for a left upper lobectomy. When we did the planar upper, middle, lower zone type quantification based on the planar images, we found that the upper zone contributed only 7 or 9% of ventilation and perfusion, respectively. But when SPECT VQ CT was used for that, in fact, it went up to 26% for ventilation and 20% for perfusion. So as a result of that, his surgical plans were changed. Here's another example. This is a tumour in the right lower lobe. He was considered unfit for surgery due to emphysema. So that was basically based on lung function tests and an assumption that all different lobes will contribute the same amount. The decision was made clinically that the patient wouldn't survive having one of the lobes separated. But when he had his SPECT VQ CT, actually it turned out that the right lower lobe only contributed to 11% of global renal function, global function for both V and Q. And so as a result of that, curative surgery was performed. So the patient was switched just by the provision of this information. They were switched from a palliative route to a curative route. So I think that's really massively important to, the service that we can provide for patients, if we can actually help with that. Here's another case, difficult case. This is a 9-month-old baby girl who'd been premature, and she had a hyperexpanded right middle lobe. The other lobes appeared compromised from a CT perspective, with this much larger sort of emphysematous middle lobe appearing to crowd out the others. And the question was, how was the right middle lobe functioning? It seemed to be quite a difference between the different tracers, and it seemed that there was poor perfusion and ventilation matching. But actually, when we did the quantification, we found that the middle lobe was really very important to the overall function, contributing 39%. So nearly 40% of perfusion was provided by that lobe. So as a result of that, the surgical plan was changed, and it was changed from middle lobe lobectomy to a watch and wait policy, because that lobe is considered so important to the patient's overall lung function. So similar work has been happening in Sydney with Dale Bailey. And so I'll just flip back to that. And our friends at the Royal Brompton have published on this if you'd like to read about that. But I'd just like to say that my surgeons really love it. I attend our advanced COAD meeting, and that's where decisions are made about whether to, for patients to undergo lobectomy or maybe coil insertion to help deal with emphysema. And our surgeons so love being able to scroll through the images that are fused with the function and the CT. They can really understand it. They struggle just to cope with just looking at the numbers, but when they can see where the function actually is in relation to the anatomy, It's a very powerful tool, and you know, I'm very happy to be sharing that with him. So finally, in terms of advanced applications, we've got PE quantification. This is work in progress. So basically, we're working with Hermes and others to try to work out, can we actually quantify what percentage of the normal lung is actually involved in PE? And we've been able to work out how to put some numbers actually onto the quotient images. And we may be doing some work with surface rendering or volumetric aspects. And Harini is our MD student, and I'm working with Left Terrace. And so that's exciting work. And the idea of that is to see whether we can triage, whether we can quantify the PE load, and whether that is helpful in patient management and triage to different management routes. And just to point out one thing, which is we do need to be terrifically careful with the technicalities of carrying out VQ. Doesn't matter what imaging technique you use, whether you use Planar or SPECT, if you don't do the injection with the patient fully supine, the hydrostatic pressure will knock out the counts at the apices. So this is the patient who had a semi-supine injection, which was then repeated. And this just shows that, you know, potential false positive PE diagnosis at the apices was averted by that intervention. So I just think that we should be very careful about how we inject our patients, and I would just advocate not injecting on injections chairs that don't lie absolutely flat. So another aspect of our quantification project will be actually assessing what kind of an impact that has. So I have worked with many terrific people. I'm coming to the end now, don't worry. Wonderful physicists in many centres, Chris Baker and Chris Sibley Allen, wonderful colleagues from many nuclear medicine departments, Harefield, Brompton, Luton, Guy's and St Thomas's. I've worked with great MSc students and now a very fine MD student, and with Hermes, the lead test objects, and Siemens, much to be thankful for. I'd like to thank you for your attention. I hope you stay safe, stay COVID-free, have fun with VQ SPECT, and don't forget how much it can be of use to patients. And I hope to see you later in 2021. And that's all I have to say. And if there are any questions, then I'd be happy to take them.
Great. Thank you so much, Charlotte, for that really interesting talk. It was really great to see such a detailed presentation of the clinical reporting of lung VQ SPECT CT. From a physics background, I don't often get to see that kind of stuff, so it's really nice to get a detailed description of how you do it. And well done for persevering with all the mouse issues. That looks really stressful.
Yes, I'm sorry, I hope it sort of scrolled through okay.
Yes, we could see it. I think there was a lag, but we could just about see it. It flashed by sometimes. But...
Oh, well, we tested it. We did our best, didn't we?
So a quick question from me first. So you mentioned the supine versus non-supine injection. But on the supine, there was still, it looked like there was still some hotter uptake posteriorly on those images. Do you know what I mean?
Oh, right. Yes, there is always a hydrostatic pressure. I'll flick back to that.
Perfect.
I don't know if you can see the thing, but
yes,
this is the patient who is supine, and a bit more supine in this view than this view, which allows this apex to get fully perfused. But there's always a hydrostatic pressure across the lungs, and that's because of gravity that basically just open up the arteries more at the base.
Right.
So if you have a patient who's sitting, that you'll literally only get the bottoms perfused. And because the patient is supine, you always do get this gradient, which sometimes gives you this quite stripy look, which is basically part of the normal physiology.
That's really interesting. Thank you. Because we often see that, and actually people have asked about on support, like whether it's an artifact of the Hermes reconstruction. No, it is not. Good.
No, it's not. Because no, it's not. And also, sometimes you get it reversed in patients who have heart failure. In fact, where there's pulmonary kind of reperfusion away from the dependent areas, so usually we see it on chest x-ray where it goes more to the apices, but in the supine image data set, actually you see more of it at the anterior aspect in a supine acquisition in patients with heart failure. And that was that's commented on in the recent Emm Guidelines.
Really?
So yeah, definitely this is a normal physiological hydrostatic thing.
Stuff. Okay, I'm going to move to the questions from the audience. So the first question is from Anthony Cartwright, and he asks, may I ask what approach you take to the optimization of ventilation exposures when using Krypton?
Well, the important thing with Krypton is that you get a really terrific seal for the patient's face. So that will just depend on, you know, the patient's likes and dislikes. We need to have a really good seal around the face. I mean, we all know a bit about that now with COVID and face masks, don't we? But there are different choices. You can have like a snorkel type thing, which doesn't work, which works very well for young people who've used a snorkel, doesn't work very well for elderly people with false teeth and so on and so forth. They tend to be much better off with a mask. So once you've got a good seal with the mask, so that you know what the Krypton that they're breathing in does actually go into their lungs, then the next thing to do is just to make sure that you don't contaminate the atmosphere, because we always get a bit of Krypton around. So I find a fan is really good just to blow anything extra away. In terms of the, so that's probably all you need to do in terms of the quality. Obviously, earlier in the day is better in terms of counts. Later in the day, you start running out of activity because of the short half-life. So I guess if you're wanting to have very good quality images, you do it earlier rather than later. In terms of the dosimetry to the patients, really, you know, I've spoken to people who say the dose is negligible, really, because it's got such a short half-life. It's just gone. So it's a wonderful tracer to be able to use. Yeah, I'm very grateful to have been able to, you know, work in 3 different centres with Krypton. And you know, when I don't have Krypton, I feel the loss. Definitely.
Thank you. So Anthony, I hope that answered your question. If it didn't, please feel free to post some follow-up. And in fact, we're going to come on to technicals later on. Okay, so the next question. How much of a problem is downscatter from the Krypton 81M images into the technetium window?
Well, I don't think that it's much of a problem, but actually we do have a test that we do at the beginning of the day just to check that there isn't too much downscatter. And if there is too much downscatter, say that it's very early and the generator is very active, there is a cutoff point. And this is one of the examples where I said to you, gosh, I hope those questions aren't going to be too technical. But
I think this is a great answer.
Steve Sibley Allen has set a cutoff point below which it's fine to carry on with dual isotope acquisition, and above which it'd be better to do separate. So
right,
at least if the activity is very high, then you can do a very quick SPECT acquisition on it.
Absolutely. That question was from William Irwin. The next question is from Spencer Manuel. He says, lovely talk, thank you. Were the Fisher/lobe segmentations automated or manual? If manual, was the process too time-consuming to be useful in regular clinical practice? If automated, were segmentation corrections needed? My impression is that the state-of-the-art Fisher segmentation is still quite challenging.
Yeah, we don't do automatic. There might well be development of that with AI, I guess, but at the moment we just put them in. It doesn't take too long, but sometimes it's actually very challenging to work out where the fissures are, and sometimes you need to, you know, go to to a higher definition imaging in order to actually be able to find them. On the whole, it doesn't take very long, and if it saves the patient having you know, wrong kind of surgery, then I think it's, you know, worth doing. Probably takes about 10 minutes. Certainly for straightforward cases, that can be delegated to technical staff. Certainly when we were doing it at Harefield, radiographers and even physicists did the segmentation. They were really good at it once, you know, you've shown them how to do it. But for more challenging stuff, for post-operative cases, then obviously it needs to kind of be in the hands of the clinician.
Yeah, perfect.
You know,
Thank you. Just
I'm a big fan of it. I think it's really helpful, and the enthusiasm of my thoracic surgeon, as I mentioned, you know, he really values it.
Great. Just to give a little bit more technical info on that. So in the Hermes application, which Charlotte did show some screenshots of, it's a manual process where you have to put control points, so 5 or 6 maybe control points on maybe 3 or 4 slices on the sagittal view. The plane is then interpolated through that. So that's the process that we do currently. And correct, the automation of that is very tricky because often it's impossible for even a human to see the lobe fissure. So a computer is not there yet.
I think it would be, you know, I think it would be a very brave manufacturer indeed to endorse automated
certainly. Yes. Okay,
yeah,
next question.
I think it has to be in the hands of the reporters at the end of the day. But it's like any processing that we do. You know, when I'm reporting a renogram, if I look at it and I don't agree with the processing, then I'll repeat it or ask somebody else to repeat it. You know, we have to be able to, you know, take responsibility for the region location.
Yeah, absolutely. Next question, we've got 3 more to go. It's from Tom Sanderson. He says, thank you. Do you use the CT for attenuation correction of the SPECT?
Actually, we don't, and I have no idea why we don't. We use CT for the attenuation of everything else, but there doesn't seem to be much tradition of it. So for some reason we don't. It would be interesting to know whether other centres do.
I think some centres do. If it's available, often the CT is not acquired alongside a VQ SPECT. So I think that's why traditionally it's not done. But there is no reason that you can't. It's available in the hybrid recon if that's what you're using for the reconstruction. So.
Yes, and we, as I say, we routinely acquire CT, but for some reason we don't do it. So it's a good question. And isn't it funny how things are different in different centres? But we don't see the lack of it. I don't see much in the way of attenuation artifact. You know, sometimes when you're like doing cardiac or something like that, you can really see like the breast shadows coming across the front like that. I don't find that that's an issue with VQ for some reason. I think it's just that the counts are generally so, you know, quite high compared to cardiac. I don't think that
a bit bigger as well that you're looking for. It's not like a, you know, a bone or a cardiac where you're looking at really small stuff. It's
no, I mean, I disagree with that because we actually are looking for subsegmental defects and things like that. So
true.
I think that when you look at the raw data sets, you know, we have quite good count intensity. But I do look at the tomograms before I report. I would notice, I think, if there was a lot of attenuation going on. So I think I think it's just not much of a problem. But it's an interesting area to explore, definitely.
Great, thank you. The next, I'll combine the last 2 questions. So we've got, oh, sorry, there are more questions, I didn't scroll. Jean Blair Saldana asks, have you used Technogas in your centre for VQ SPECT? And Zani Win asks, have you used other ventilation agents for SPECT?
So I don't know how, but I've never worked in a centre with Technogas. I don't know why that is, because it's really good. Of course, you couldn't do dual isotope work with it, as we've done with the Krypton here. I have worked with DTPA Aerosol, and it's not my favourite thing in the world. Usually it's suboptimal, and I do concur with the Emm Guidelines saying that DTPA Aerosol is not ideal, and that we should be switching to Technogas if we, you know, on Krypton light days. I've seen a lot of VQ SPECT done with Technigas from other centres though, and it's a lovely agent, and it should be entirely successful. Of course, you have to do 2 acquisitions. You do a sort of low dose Technigas acquisition and then flood it with MAA. That's the usual way to do it. But it's a very successful thing, and you can do the same processing that we've shown here on that with quotient imaging and so on and so forth.
Great, thank you. Zarniwin also asks, do you consider ventilation scan as an aerosol generating procedure? I guess this has a COVID tone to it.
Well, we don't. As I mentioned, we use Krypton. We don't use DTPA aerosol, and we use Krypton, and we don't consider it an aerosol generating procedure. I think even if we were using an aerosol, there's a lot of evidence to suggest that DTPA nebulizer, actually the aerosols are produced within the nebulizer, not within the patient, and therefore it shouldn't contaminate the atmosphere. But I know that a lot of centres have actually stopped their ventilation service, which I think is a terrific shame, because it's really so hard to interpret perfusion scans without the benefit of ventilation images, as I showed from our bit of local research. I think we found that we had 8% false positive if we stopped doing the ventilation phase, even with using CT. So I'm a great advocate of using ventilation images. I don't think we should be missing them out.
Interesting, thank you. We have another question from Jean Blair Saldana. Do you still perform planar images or just VQ SPECT, or both?
Just VQ SPECT.
Lovely. And this question from, I'm sorry, I will get this name pronunciation wrong, Carrie Fruska. What collimator are you using with Krypton? I think that was probably answered in your presentation with the SpongeBob experiment. I think so. It was a medium energy collimator.
Yes, I think so. I think that's right. But I mean, if you want more details, then I can certainly send them to you. I haven't actually got them right here, right now.
What else do we have? So this question from, we're getting near the end now, for real this time, from Nadia Haider. Do you recommend VQ SPECT for patients more than 80 who have underlying COPD and heart failure?
If they can lie flat, and if you've got the capacity to do CT, then yes. And we do quite a lot of elderly patients, because one of the contraindications to CTPA is if they're in renal failure. We have a big renal failure unit close to us, so yes, absolutely. I think if with the combination of a good perfusion image set, a good ventilation image set, and CT, we can work our way through all the different abnormalities.
Okay, great. We've got some thank yous and some very interesting talk comments here as well. But I think we've come to the end of the questions now. So thank you again, Sean.
Actually, sorry, Helena, there were a couple of questions I noticed in the list that maybe we skipped. There's
sorry.
One from Lynn McLaughlin and Thomas Biggins as well. A bit
Sorry,
further back.
Got lost in the... Oh, yes, thank you. Okay,
No
from Lynn McLaughlin, we have how long overall is the acquisition time for ventilation SPECT? And is patient tolerance an issue, assuming they are venting the Krypton for the duration of the acquisition?
Yeah, so it's about 15 to 20 minutes. I think that the technologists or radiographers running the list might speed up or slow down the acquisition a tiny bit, depending on how much Krypton there is, what stage of the day we're at. But on the whole, I think it's about a 20-minute acquisition for both phases, if we're doing it as a simultaneous dual isotope acquisition, which I think is the same as most SPECTs, and I think most patients tolerate it well. Obviously, if they can't lie flat, then they can't really have this scan, and we would then, I guess, switch to a planar imaging, but with all the hesitations over the lack of accuracy of the interpretation. Or else the patient should go and have a CTPA, because it's a much quicker acquisition. CTPA is over in 3 minutes or something by the time you got the patient set up and scanned.
Okay, lovely. I think that is truly it now.
Okay.
Thank you again for a really interesting talk and for taking your time to do this. I hope everybody found it interesting. If you missed it, or your colleague missed it, or you want to see it again, it will be available as a recording on the Hermes websites, or you can email us to get a link. So thank you, everybody. Thank you, Charlotte. I will now finish the webinar.
Okay, thank you very much.
Thanks. Bye.
Bye.